Good evening. It's so nice to be back here with you in person. As Roger said, I have missed you all so much. This is really a special night as we get to meet our brand new board-certified clinical specialists who've dedicated themselves to excellence in our practice. For me, this is also a magical night because, of course, no one embarking on a career in physical therapy ever believes that they'll be the one to grow up to give the McMillan lecture. But then, I was born on Halloween, so magic has always been part of my life. When we're young, we all see the magic. Fireflies dancing on a warm summer night, wiggly little tadpoles growing legs and turning into frogs, shooting stars. Magic. This evening, my mission is to remind us all of the magic in physical therapy. Not magic in the sense of flowers pulled from a top hat, but real magic, creating transformations and foreseeing the future. So, more about magic later. Of course, I need to start by thanking those who brought me here to this place. My deepest gratitude to the Mary McMillan Selection Committee, to the 2022-23 APTA Board of Directors. I owe a debt of gratitude to some of the giants of our profession, whom I was fortunate to have known but who are no longer with us. Florence Kendall, Steve Rose, Linda Crane, Charles Magistro. All these individuals shaped my early perceptions about what it meant to be a physical therapist. Thanks to my wonderful colleagues who had a hand in my nomination, Steve Wolf, Carolee Winstein, Rick Siegel, Kathy Gilbody, Rich Shields, and Stuart Binder-McLeod. And then, because my world is admittedly neurocentric, I'm also grateful to two colleagues, Chris Powers and Linda Van Dillen, who throughout my career have shared their brilliance with me whenever I needed a touchstone in the ortho world. I'm grateful to everyone in each of these photos. And honestly, I could spend my entire time just thanking people, so I apologize in advance to those I can't name by name. Please know that you're in my heart. For someone who comes from a small family, sometimes just as important as the family you grow up in is the families that we grow into. Being a physical therapist has given me the opportunity to be part of communities with a shared purpose. The people that I've met through these groups have truly become my extended family. Thanks to Betty and Don Leslie, who've been such an important part of my Shepherd family. Their support has made it possible for my research team to test new ideas as the foundation for our funded grants. Their dedication to people with spinal cord injury has been an inspiration to me and so many others. I owe a debt of gratitude to my small but mighty mom, who at just 22 years old immigrated from Cuba to Maine in the dead of winter. In her day, she was an incredible seamstress, as you can see from these photos from our centennial celebration from my hometown. She made the outfits herself based on old photographs. I credit her with instilling in me a value and a respect for measurement and precision. I can still hear her voice whenever I'm sewing myself saying, "Measure twice, cut once." I'm very fortunate that she's still in my life, but she was unable to travel here today. Most especially, thanks to my husband of 25 years, Alec, for his exuberant support of everything I do. And my son, Trey, who's the joy of my life and whose curiosity about the world has always been contagious. He celebrates his 22nd birthday this Friday. Both of them have been a constant source of support and encouragement to me to share with my profession the time that would have been theirs. So, back to magic. In middle school, I was a candy striper at a nursing home, and it was then that I discovered that physical therapy had magic, helping an older man with a stroke who could barely move his leg at first learn to walk again. Teaching a frail older woman who got stuck in her own chair and couldn't get up how to use her body mechanics and to strengthen her legs so that she could get herself out of her chair. Magic. Who wouldn't want to be part of a profession that did magic? So, of course, I went to PT school, where I learned about the magic of sodium and potassium channels that open and close at just the right time to generate an action potential. And I learned about myelin that insulates the nerve to make that transition more efficient, and how I, as a physical therapist, could harness that magic with electrical stimulation and activate muscles at just the right time to produce a contraction to help a person walk. Then I went on to get my PhD, and I was completely seduced by the magic of turtle scratching behavior. So, if you happen to be sitting next to one of my neuro colleagues, you may have heard them let out a sigh. This is probably the 50th time they've had to listen to me talk about turtle scratching and central pattern generators, which of course are the original CPGs. But it's still fascinating to me almost 30 years after getting my PhD, and as you can still see, I still manage to work it into my talks whenever I can. Even after a complete transection of the spinal cord, central pattern generators can produce complex behaviors like walking, swimming, scratching, with no input from the brain. Even humans have these CPGs, and they're part of the reason that we don't have to think about activating our leg muscles every time we want to walk or run or even skip, well, maybe not skipping. With the help of funding from the foundation, I became the first physical therapist with advanced expertise in turtle scratching behavior. But not the last, not the last. My first NIH grant built on these foundation-supported studies, focusing on helping people with spinal cord injury walk by using stimulation to activate spinal circuits at just the right time in the step cycle to elicit a flexion reflex response. Turtles, humans, all vertebrates evolved to have this elegant, distinguished, and distributed system of control. So, evolution. When you learned about evolution in middle school, for sure, it seemed like magic. Perhaps like mine, your biology teacher used the example of the peppered moth. The Industrial Revolution caused sooty air pollution that blackened surfaces and killed off lichens. So the pale form of the moth that had done so well before was now more obvious to predators, while the darker form was now better camouflaged and so more likely to survive and produce offspring. There are lessons that we can learn from the process of evolution in the natural world, where the key evolutionary forces are natural selection and adaptation. Selection, wherein traits that are not suited to survival are eliminated, leads to adaptation, where beneficial characteristics become more prominent in the population. While these processes occur spontaneously in nature, they are likewise essential for our own profession. But if our patients are to benefit from our powerful knowledge and rich skill sets in this dawning world of precision practice, we cannot wait for these processes to occur spontaneously. We must drive our own evolution with intention. So, what is precision practice anyway? Well, the January 2022 special issue of our journal, PTJ, focused on precision rehabilitation as a component of precision medicine, which is the tailoring of medical treatment to the individual characteristics of each patient, to classify individuals into subpopulations that differ in the biology and/or progress of those diseases that they may develop, or in their responses to specific treatment. Tonight, we will delve into ways that we can leverage our own kind of magic, our specialized knowledge and skills, to propel the evolution of physical therapy toward precision practice. I believe this evolution will require that we rise to challenges and opportunities in 3 areas. First, focus our energies on excellence in our own validated knowledge and skills. Second, champion movement measures as biomarkers of health-related conditions and outcomes. And third, decipher the mechanisms of movement-related change in the human body. So the first challenge is that we focus our energies on excellence in our own validated knowledge and skills. Since the early 1990s, when Gord Guyot introduced the term evidence-based medicine, all healthcare disciplines have really worked to shift their practices from decisions that were based largely on intuition, subjective experience, and tradition to better align with research evidence, some with greater success than others. One of the hardest parts of committing to evidence-based practice is letting go of practices that are long-standing tradition. An important aspect of selection is making choices about whether or not doing things as we've always done them is truly in the best interest of our patients and our progress as a profession. Our PT school curricula is overflowing. What professors outside of physical therapy have an average class size of 3 hours? We have to make hard decisions about what to let go of, stop teaching, and stop doing. Only this way will we have time to truly be experts in the evidence-informed core knowledge and skills that makes physical therapy a unique and impactful profession. In the neuro world, the Academy of Neurologic Physical Therapy Board of Directors bravely called out specific areas of clinical practice in neurologic physical therapy that lack evidence of comparative efficacy or effectiveness for people with neurologic conditions. They said, clinicians have a moral and ethical obligation to prescribe treatments with the best available evidence. To persist with approaches that are not supported by the best available evidence runs contrary to the vision set forth by our predecessors and the tenets of evidence-based medicine. I say they bravely called these out because the treatment approaches they named by name are traditional neurologic physical therapy interventions that were developed based on early theories of movement control that are no longer tenable. But the practices continue, despite the fact that they lack efficacy or evidence for adults with neurologic conditions. The fact is that many of these approaches are still taught in our PT programs in our adult neuro classes. The lack of evidence for some of these practices is not lost on those outside of our profession. 2 years ago, in a New York Times article, there was this very point that was made. The article was entitled, "What to Look For in a Physical Therapist. Not all PTs are created equal. Find a professional who values evidence over anecdote." The journalist makes the point that there is a wide variation in our practice, saying the field has struggled with a lack of uniformity and a lingering reputation for pseudoscience, leaving patients unsure whom to trust. Take ultrasound, for instance. What? Is she talking about my profession? My physical therapy? Well, you know, I'm a neuro rehab researcher. I hadn't really thought very much about ultrasound for many years, since PT school, in fact. So I did a bit of digging into the literature to better understand the state of that science. What I found essentially agrees with the conclusions of the New York Times journalist. While there are a few indications for which ultrasound appears to have some modest value, for the most part, the studies that support its use don't compare it to other interventions that actually represent best evidence and active interventions. Beyond the question of whether interventions that are not evidence-informed does a disservice to patients and harms our profession, In this New York Times article, my Emory PT colleague and ethicist, Bruce Greenfield, questions the ethics of charging and getting reimbursed for interventions that lack evidence. In addition to letting go of old practices that are not informed by evidence, there's another aspect to selection. We must focus on excellence in our own validated knowledge and skills. If you read through the past McMillan lectures, which of course is the first thing that everyone does when asked to give this lecture, you'll surely be awestruck by the wisdom of our colleagues. Many of them refer to the importance of striving for excellence in our practice. While we would all love to be excellent in everything we do, the reality is that excellence requires focus and selection. Excellence requires that we make choices as individual clinicians, as educators, researchers, and as a profession about what we'll focus our limited time and energies on. For excellence in physical therapist practice, we must be excellent in our own validated knowledge and skills and tame the impulse to reach beyond our mission as a profession, encroaching on practice areas of other disciplines. You might not know that in my early days as a physical therapist, I was very involved at the chapter level, serving on the board of directors and as a delegate to the House of Delegates. I am still fascinated by the House. And each year, I quiz my delegate colleagues about what is the hot RC of this session. Last summer, I felt my heart race when I learned about a well-intentioned RC about PTs prescribing medications. My first thought was, we are so excellent in our validated PT knowledge and skills that we should be looking to expand into other areas of medical practice? This is just one single example. We are constantly bombarded by distractions that have the potential to thwart excellence in our own validated knowledge and skills by diverting our attentions and our energies. As it happens, on Friday, the Academy of Physical Therapy Research will host the annual Eugene Michaels Research Forum, where we'll actually debate whether physical therapists are encroaching on areas outside our scope of practice when we incorporate measures of psychological factors. As you can imagine, in this debate, I was assigned to the con side. I actually find this topic rather ironic, given that we have considerable work to do to elevate the status of movement-related measures that is the foundations of our practice. I'll come back to measurement in a bit. If we fail to make choices about what is versus is not in our scope of practice, we risk the fate of the dog with the bone in Aesop's fables. You remember, one day Fido is trotting along with his prized bone and he has to cross a bridge. He chances to look down and there in the water, lo and behold, is another dog with a bone that looks even yummier than his. He tries to snap up that bone too, and you know the story. He drops his bone and it sinks to the bottom of the river, lost. This is an excellent illustration of the selection problem that we are faced with in our profession. Selection mandates that we pay greater attention to excellence in the knowledge and skills that make us a unique and impactful profession. Let go of practices that have no evidence for their value and steer clear of adding shiny new practices that draw us in only because they're hot or exotic or because we imagine they'll expand our opportunities. Every traditional practice that we hold on to despite a lack of evidence, and every new thing that we add to our practice means that there's less time to teach, learn, and practice our own validated knowledge and skills that truly make a difference to our patient. One area where we would do well to truly strive for greater excellence is in measurement. Okay, so I can hear some of you thinking, Edee, you spent your entire Mealy lecture back in 2012 talking about measurement. Hasn't there been any progress? Well, there has been progress, thanks to the Academy of Physical Therapy Research and the support for the evaluation database to guide effectiveness. There is much greater awareness of the need for standardized measurement. And the shout out is also deserved by the Academy of Neurologic Physical Therapy that has had an ongoing commitment to publishing and updating recommendations on standardized outcome measures for different neurologic clinical populations. But let me share a story with you. A large part of what we know about outcomes after spinal cord injury comes from data that's collected by the Spinal Cord Injury Model System Centers. And this data is uploaded into the National Spinal Cord Injury Statistical Center. Before it can be added to the database, though, it needs to pass a quality check. Who's responsible for collecting this data? In many model system centers, it's the physical therapist. In the current funding cycle, I happen to serve as chair of the Project Directors Consortium for the 18 funded spinal cord injury model system centers. And I can tell you with confidence that all centers have measurement errors that need to be corrected before their data can be added to the statistical center database. So earlier this evening, you had a chance to meet Kelly Thatcher, a bright young PT who I'm lucky to have as part of my research team, and who received her certification as a neurologic clinical specialist. I was wondering out loud why it is that physical therapists who are phenomenal clinicians have such difficulty and don't take good care with their clinical measurement. And Kelly said something that I thought was really insightful. She said, Edee, therapists get their gratification from treating their patients. They feel like they know when their patients are getting better. So measurement is just something that's a requirement of their job, not something that's really meaningful. While her point about where we get our gratification from was really well taken, I'd like to remind us all of how easy it is to be tricked by our intuition about measurement. So I hope you'll indulge me the use of one slide from my 2012 Maley lecture. If I were to ask you which of these tables is longer, you'd likely tell me the table on the left. But if I take the same tabletop shape that I created and I move it over to the right, you can see that they are exactly the same size. In fact, when I was practicing my talk at home, my husband Alec did not believe this, so he got out his ruler to verify it was true. So you're welcome to come up and talk to him later this evening. We can't rely on our intuition. Measurement is the heart of precision. How can you have precision practice without precision measurement? Only by measuring change can we really know if our interventions are effective. We need to elevate the status of measurement in our clinical practice so it's not just a job requirement, but something that every clinician sees as essential to their clinical decision-making and a way to quantify the true value of their interventions. So, our evolution requires that we master our own magic through selection. Only by letting go of practices that lack evidence and taming the impulse to stray from our mission as a profession, emphasizing our own validated knowledge and skills, in particular measurement, will we truly achieve the excellence that is essential for precision practice. So now let's turn our attention from selection to adaptation. And you will see that we have an unprecedented opportunity to lead the way in precision medicine precisely because of our expertise in measurement of movement. If I was to tell you that beyond the ability that we have to change people's lives through our PT interventions, we have the ability to predict the future, would you believe in our magic? We can predict the future. We can make predictions about future function, which has untold value for helping our patients plan for their own futures and for identifying the best ways to focus our interventions. We're able to make these predictions because movement itself is a powerful biomarker. You may have noticed that pretty much everything that you read these days about precision medicine includes a discussion of biomarkers. So, the second challenge before us in the dawning world of precision practice is to seize the opportunity to champion movement measures as biomarkers of health-related outcomes. I confess that I hadn't really thought very much about movement as a biomarker until about 5 years ago, when a smart young PhD biomedical engineer at the University of Pittsburgh, who'd been so fascinated by the knowledge and skills of her PT colleagues that she went back and got her own DPT, asked me if I would serve as a mentor on her NIH Career Development Award. Lynn Warabe's research showed that people with spinal cord injury make leg movements during sleep, and these movements can help predict the likelihood of their future walking function. Having a biomarker that can classify who is and is not likely to walk again helps our patients with their goal setting, helps direct valuable therapy time to the most appropriate intervention, and thereby improves their outcomes and quality of life. Before we discuss other examples of movement biomarkers, let's talk a bit about what biomarkers are and why they were essential for precision practice. So the consensus definition of the NIH FDA Working Group on Biomarkers, Endpoints, and Other Tools, or BEST, is that a biomarker is a defined characteristic that is measured as an indicator of normal biological processes or responses to an exposure or intervention. So while there's a tendency to think of biomarkers as high-tech measures like biologic, imaging, or genetic markers, in fact, biomarkers are much more broadly defined than this. The key to the value of a biomarker is that it contributes to improved decision-making. In the NIH Rehabilitation Research Plan of 2021, the rehabilitation community is challenged by the NIH to advance precision medicine approaches for rehabilitation by supporting the development and use of biomarkers associated with specific injuries, illnesses, and disorders that are prognostic or that guide prescription of rehabilitation interventions. The BEST working group identifies 8 different subtypes of biomarkers. If we think about it, we know that there are excellent examples of movement-related biomarkers. Walking speed and grip strength are robust prognostic indicators of future frailty in older adults. The 6-minute walk test is a widely accepted proxy biomarker for exercise tolerance. We know that scores on the Berg balance scale indicate fall risk. When collected in a standardized way, these movement-related biomarkers inform clinical decision-making, and they don't require high-tech equipment and resources the way other types of biomarkers do. Let's take a look at prognostic biomarkers. These are used to identify the likelihood of a clinical event or disease recurrence or progression in patients who have the disease or medical condition of interest. So, I've already told you about how leg movements during sleep can serve as a basis for walking prognosis in people early after spinal cord injury. Imagine the benefits to a patient with stroke if there was an algorithm based only on clinical measures that is able to prognose their future arm and hand use without the time burden, cost, and resources required for imaging and electrophysiologic measures. How about a measure based on trunk movement that indicates the likelihood of recurrence of low back pain? Or being able to give guidance to an athlete that they are at greater risk of non-contact ACL injuries based on assessment of their hip muscle strength. These are all movement-based prognostic biomarkers that had been identified by physical therapist researchers. There's also evidence from a physical therapist researcher that movement can be a predictive biomarker, showing that asymmetrical arm swing can help early diagnosis of Parkinson's disease long before the individual develops the cardinal motor signs that are basis for a Parkinson's disease diagnosis. I challenge you to rewatch some of those old Back to the Future movies and see what you think about arm swing symmetry or asymmetry in a 30-year-old Michael J. Fox. As the world of healthcare moves toward precision practice with greater dependence on biomarkers, it's essential that we develop and promote the concept of movement-related measures as valid, accessible, and economical biomarkers to facilitate improved clinical decision-making and assist with planning of care. So finally, to adapt to the dawning world of precision practice, we must decipher the mechanisms of movement-related change in the human body. To give this point some context, let's come back to this 2021 New York Times article that we discussed a little bit earlier. The journalist makes the justifiable point that many interventions physical therapists do lack evidence, and as we discussed earlier, focus a lot of the story on passive interventions like ultrasound. In this article, both Marilyn Moffat and Jim Gordon point out that one of the things in our PT toolbox, exercise, has abundant evidence for its preventive and restorative effects. In her 2016 McMillan lecture, Carol Lewis reminded us that exercise is medicine, and she catalyzed us to take charge of exercise prescription. Okay, so while we're on the topic of Carol, this is an opportunity for me to make a public disclosure. Carol has been a great source of inspiration and encouragement to me throughout my career for as long as I can remember, and it's been very flattering to me over the years that people often mistake me for her. So here's my dilemma and my disclosure. What to do when people come up to me and say, "Oh, can we have a picture with you? We just love you, Dr. Lewis." So if you've ever taken a selfie with Dr. Lewis, you may just want to go back and check. I'm just saying, you know. So back to exercise. In last year's Maley lecture titled "Exercise is Our Medicine," Sue Whitney made a strong case for the value of exercise. In fact, the idea that exercise is medicine is so potent that the American College of Sports Medicine has registered this phrase as the trademark of its global health initiative. But in fact, our medicine, our magic, is even broader and more inclusive than exercise. It's movement in all its forms. Exercise, practice, training, from high-intensity aerobic exercise to get your heart racing and promote release of brain-derived neurotrophic factors to high-repetition, task-specific motor training to promote neuroplasticity. But how is exercise medicine? Understanding the how movement influences the human body is the only way that we can truly understand our magic. Understanding the how is the basis for refining our interventions and fitting them to the patient for precision practice. How many times have you read a research article that concluded future research is needed to understand the mechanism? As we evolve toward precision practice, we are duty-bound to understand how movement in all its forms works its magic. Over the years, many of the studies of my own research team have focused on understanding how physical therapy interventions change the nervous system in people with spinal cord injury. Whether these were training studies to promote cortical plasticity for improved hand function, illustrated on the left by before and after changes in cortical motor evoked potentials, or spinal circuit plasticity to improve walking function or reduce spasticity, illustrated on the right by posterior root motor reflexes before intervention in blue and after intervention in red. It's been clear that movement, practice, and training change the nervous system in ways that promote improved function, even for people who lived with spinal cord injury for many years. But my lab is certainly not alone. Let's take a quick tour of some of the studies that have been published in just the past 4 years by our PT colleagues that have provided answers to this question of how exercise, movement, practice, and training result in beneficial outcome. In last year's January issue of PTJ, you read about the genetic and epigenetic changes in paralyzed skeletal muscle associated with low-force electrical stimulation, resulting in the development of a new intervention approach for people with spinal cord injury that provides the benefits of exercise without the fracture risks that are associated with high electrically evoked forces. Our PT research colleagues have also shown that exercise intensity influences circulating neurotrophins, particularly brain-derived neurotrophic factor, in people with stroke. It moderates inflammatory biomarkers in women with breast cancer and in people with Parkinson's disease. It increases blood flow in brain areas associated with memory in older adults. Our PT research colleagues have shown how training increases cortical excitability and activation in youth with cerebral palsy, how brain activities differ during skill acquisition versus immediate retention. And it's also shown that eccentric walking training improves plasticity of spinal cord white matter for improved conduction of descending signals in people with spinal cord injury. These studies are evidence of the power of movement in all its forms: exercise, practice, training, to change the body systems in fundamental ways. Only by understanding the underlying mechanisms that make movement, exercise, practice, and training so powerful will we be able to refine our interventions and truly master their magic for precision practice. We have the expertise that allows us to adapt and thrive in this dawning world of precision medicine. Let's champion movement measures as biomarkers to enlighten colleagues outside of physical therapy how movement can be used to predict, prognose, monitor, and diagnose health-related conditions. Let's dig deeper into how exercise, movement, practice, and training change the physiology and structure of the body. Tonight, I shared with you 13 examples of how PT researchers are blazing the trail in demonstrating the value of movement as a biomarker and deciphering the mechanisms of movement-related change in the human body. While I pulled these 13 examples through a random PubMed search, it should give us all great pleasure and satisfaction to note that of these 13 articles, 10 had at least one author that had been funded by the Foundation for Physical Therapy Research. So each and every one of you who's ever contributed to the Foundation has helped our profession lead the way in adapting to the dawning world of precision medicine. And with your continued support of our Foundation, there's so much more we can do. That's all I have for you tonight. I'm forever grateful for the privilege that it is to call myself a physical therapist and to count myself as a member of your family, the physical therapy family. We have the knowledge and skills to shine in the dawning world of precision practice. Let's all remember that we have magic. Thank you.